panel discussions are innovative. It's a great benefit for anyone who takes the time to attend this meeting.
And there was a very practical handling of how to use imaging, how to make interpretation.
Also, it touches various topics, both on the coronary and structural side. Very insightful, exchanging scientific data and results of trials.
And several live cases have been performed to show complex, innovative procedures. Several workshops were another very exciting session coming up. So that's about how to navigate the tough terrain. So we are now in the coronary zone. And let me invite Dr. Rustam Detov from Australia. He's just scaled some very high peaks in the Alps. Rustam, are you there in this? So Dr. Sanjog Kalra, he's already here with us. Kirti Punamia, is Kirti out here? And we'll ask him to join us. Dr. D.S. Chadda, Dr. Chadda is going to be doing the first presentation, so I hope your slides are ready. Can I invite Dr. Hani Regi, Dr. Omar Hassan, Dr. Arun Mohanty, Prashant, Dr. Pawan Goyal, Dr. Asif Hassan, Dr. Weber Bandel, Dr. Gautam Nayak, and Dr. Amit Bhushan. So can I invite our first speaker, Dr. D.S. Chadda?
Good morning, everyone. Thank you, Dr. Atul, for having me here. For the next 7 or 8 minutes, I'll share with you a calcific chip case. Yes, calcific CAD is challenging because lesions are complex, they have high syntax score, they LM with TVD, lesions are tight, angulated, often ostial in location, you have CTOs, and very commonly you have sole surviving vessels. Lesion morphology is complex, there are nodules, there are thick circumferential calcium plates, and invariably these patients are elderly with LV dysfunction and they have multiple comorbidities to deal with. I'll share with you one case, 79-year-old male, diabetic hypertensive with COPD. He had anterior wall non-STEMI in December 21. He had severe LV dysfunction with regional wall motion in the anterior wall. EGFR was 58 and the angiogram was as shown here. You have a tight distal left main, circumflex is totally occluded, and there is some retrograde filling of the RCA. RCA was also totally occluded. And what you see in the magnified images is a big nodule in the distal left main along with tight calcific disease in the proximal part of the LAD. Well, he needed revascularization, and of course, you have two options, CABG and PCI. We know that when you are dealing with the chip case, the patient comorbidities like advanced age, frailty, diabetes, they contribute. You need there are some hemodynamic parameters which add to the chip complexity and the complexity of the lesions. If you look at the complexities present in the present case, this was an advanced age, he was a frail diabetic, he had COPD, he had LV dysfunction, he had two chronic total occlusions with LMCA bifurcation disease with lots of calcium. Now, if you have to choose the options of revascularization, you have following parameters to look at, certain clinical parameters. So he definitely needed urgent revascularization. So that went in favor of PCI because you can do it fast. But he definitely had some serious comorbidities which required attention, advanced age, and he had some poor general performance. Well, factors going in favor of CABG was low ejection fraction, and he had high bleeding risk. The anatomical factors are more in favor of CABG in that he had very complex anatomy with CTOs, severe calcification, long disease, and the final thing is what patient chooses, and you have to discuss all these options with the patient relatives, and they opted for CABG. So we were happy that this was a complex case and CABG could have done a complete revascularization. But the clinical course was that while he was being taken up for CABG, on that day he developed pulmonary edema and he was stabilized, but thereafter the relatives withdrew the consent for CABG. They said, no, they are not going to opt for CABG. And they said, you please go ahead and do the PCI. And the challenges were that he was a frail diabetic with advanced age, severe LV dysfunction. There was a sole surviving calcific vessel with very high Syntex score. We had distal left main involvement, CT of LCX-RCA, and there were nodules in the distal left main. So it required a lot of planning. When you have a CHIP case, you need to plan. And we thought we'll do this case under elective intubation. And the toolkit was, we needed groin access, both artery and vein, 7 French, EBU guide, because we needed good amount of support because there was a calcium to deal with. We chose IABP for LV support because the patient did not have enough funds to opt for Impella. We wanted to put a pulmonary wedge catheter. We chose a couple of workhorse wires. We also kept the CTO wires standby, a microcatheter for exchange, guide catheter extension, which we thought would be most essential. Imaging modality, we chose IVUS because we thought it would work much better than OCT in this scenario because of LV dysfunction. And we had kept all the plaque modification tools ready with us. Apart from the toolkit, you also have to have a very congenial environment with good support staff, well-trained staff, so that they are able to follow your instructions. We thought of using rotational atherectomy as the tool of choice, and we also kept intravascular lithotripsy standby. Well, we knew that we were going to use combination of tools. No calcium case can be done with a single tool. The approach would have been, if the lesion is balloon crossable, then we go ahead and image. If not, then we'll have to rotablate. And as we know, that rota is the only front cutting device which will make us progress. Then thereafter, we would do imaging and then characterize the plaque morphology, do the aggressive dilatation and optimal stent deployment. So imaging would occupy the center stage, will help us plan the case. So IABP was put, we put a TPI line. The wiring was very difficult. We took a polymer tip wire. We had, as I mentioned, we had kept a CTO wire ready. Finally, the knuckle mashing, the wire went through, but the microcatheter just won't cross. We thought if the microcatheter goes through, we'll be able to change it to the rota wire and do the rotablation. So we had to do granuloplasty. We took a 075 balloon. Fortunately, that crossed. After the granuloplasty, we went ahead and did the rotablation. We chose a smaller burr first, we created, and thereafter we did in a step burr fashion, we ablated the plaque. And the protocol which we follow is, we always choose the 1.5 burr. If the lesion is crossed, there is happiness. If it doesn't cross, we downsize because it has a greater penetration force. If the lesion is crossed, happiness. If it doesn't cross, we change to excessive wire because this changes the wire bias. And if it does not help, then we go back to the 1.5 burr because it's got a greater diamond covering. And so it's basically a combination of rota wires and burrs which help you get over uncrossable calcific lesion. What is important is that you should avoid forceful manipulation of these burrs. Once this was done, we did dilatation, and post-dilatation, we thought we are going to use IVL here because there was a lot of calcium which we had visualized. So our IVL balloon didn't cross, so we had to use a guide extension using balloon anchoring technique. We got the guide extension in, and post that, we did the IVL of the proximal and distal left main. And thereafter, we did adequate dilatation. Now, this is very important. If you've done the IVL, that doesn't mean that the bed is well prepared. You need to use a larger size balloon and prepare the bed, fracture the calcium, and seeing is believing. We had optimal bed preparation. As you can see, multiple fractures, and we know that it's only dissections and fractures which lead to adequate luminal gain. So everything was visualized, and once we were sure, we chose stents, and we had used proximally Megatron, and distally we chose Synergy. And these stents were optimally deployed, and this was the final results. You can see in this adequate filling of the RCA. We did not attempt at this stage the RCA. We, of course, had no plans of chasing the circumflex. So the essential ingredients of a CHIP angioplasty are that these patients are invariably elderly with LV dysfunction, and they have multiple comorbidities. So you have to choose your revascularization strategy very judiciously and using the heart team. You have to support the LV upfront rather than doing it during or after the procedure. They have complex lesion morphologies, which mandates that you use a combination of atherectomy tools, and you should always try and keep the procedure simple. You should aim for as low a Syntex score as possible, but you have to do a meticulous planning, and which must be followed up with adequate pharmacotherapy. Don't strive for perfection in these cases because that will invariably lead to complications. Well, we are dealing with the aging population, and there is a tremendous growth of comorbidities, and they present to us with very complex lesions. Unplanned interventions in these patient population can be catastrophic, so one has to plan and then execute these cases. Interventions in this age group makes them gain a lot because they are the group which are denied, and they are the group who have a progressive downhole course if you don't intervene. And a well-run CHIP program is considered to be a high risk and a high reward paradigm which benefits the undeserved patient population. Now, in this regard, I must also add here, your support staff has to be good, and you have to have a very congenial administrative environment to support you. Then only can you run a good CHIP program. And thank you for your patient hearing.
Yeah, thank you, Dr. Chadha, for a nice demonstration of a very heavily calcified CHIP case. There is initial experience of all of us about orbital. Do you think orbital is a good tool for this kind of patients, or ROTA is your choice? Why it is so? What would have been the plan? And sometime the algorithm, what we see is balloon uncrossable has been changed. If you are doing imaging, image catheter uncrossable lesion, straight away go to ROTA rather than balloon.
So a couple of points which I must answer. This case was done in 2021. Orbital was not available. Had it been available, even then I would not have chosen orbital. This is a balloon uncrossable lesion. So in a balloon uncrossable lesion, orbital has got absolutely no role to play. When you're finding it difficult for your micro catheter to go across, there is absolutely no point pushing, opting for orbital, which probably requires a greater space to get in. ROTA is a front cutting device. It's got diamond chips right at the top, right in front. So it is a tool which is meant for uncrossable, very tight lesions because it kind of creates a space for you to start working on. Now, if you see such big nodules, orbital is a good tool. And if you feel that the rotational atherectomy has created space, and if you feel that the patient has got deep pockets, you can opt for an orbital after this and do orbital atherectomy. You can do kind of complete debulking. Orbital is a debulking tool, whereas ROTA is a plaque modification tool. So we modified the plaque, and then we chose IVL because we had noticed very thick plate calcium and multiple layers of reverberations and thick nodules. So we wanted the plaque to be very nicely modified, because if you deploy a stent without modifying the plaque, it's the biggest disaster which you can get into, because thereafter you start chasing OP and NC balloons going to high pressure, which kind of endangers. So if you modify your plaque well, job is done.
Cobb. Yeah. So you mentioned about the uncrossable ROTA lesions in the algorithm. Maybe in the roller coaster, 20% patient required a second device. So my question is, opening another ROTA, another cost, would you consider guide extension catheter if the one particular size of ROTA is not crossing? How do you place guide extension catheter in ROTA uncrossable lesions?
So the guide extension catheter is just going to give you adequate support. You need kind of support, and I always say that when you're dealing with calcium with atherectomy tools, you need good support. People talk about support in CTO cases. You need good support while doing calcium cases also, because if your burr is not engaging the lesion, it will not modify it. Having said that, you always get into a situation where you use a particular size. I mentioned, I think by mistake I mentioned 1.2. We chose 1.5. It was not crossing, so we had to downsize to 1.25. 1.25 has a greater penetrating force, and it creates a space. So you have to do it. It's not that you choose one burr and it kind of helps. Having said that, even in the present time, I can go with 2 burrs. It will still be about half the cost of the orbital atherectomy.
Yeah. If there are no more questions or any discussion, we'll go to the next topic by Impella Saved the Day by Dr. Prashant Kaul. Can I invite Dr. Prashant Kaul?
So good morning, everybody, and thanks to Dr. Mathur for the kind invitation. Once again, always lovely to be in Delhi, especially when the test match is going on in London. So keenly following that as well for the next session. So I was asked to present an Impella case. Here are my disclosures, none really relevant to this discussion, but this is a 55-year-old gentleman, so quite young, with the usual risk factors. He's hypertensive, has cholesterol, and he presented with acute coronary syndrome and had a low EF, 15 to 20%. And so he was sent for diagnostic angiography. And this was the initial diagnostic angiogram that was done at an outside hospital. So the right coronary is occluded proximally. You can see there's some bridging collateral supplying the rest of the right coronary. And then he has some distal left main disease. There's a high-grade lesion in the circumflex and also in the proximal LAD. So, and then this is his LV gram with contrast, so clearly decreased LV function as well. So what do we think the next steps are here? So I might pause just for a moment to see what the panelists might do here. So multivessel disease, ischemic cardiomyopathy, initially referred for surgery, but deemed ineligible because he had very bad asthma. He was a brittle asthmatic, and so surgery was turned down. EDP at this time was 35. So thoughts here, what would you do? Stop. Okay, stop. And then what? Can we just get the mic? I don't know if that mic's on.
Yeah,
there you go.
I would stop at this stage because
Yeah.
this patient's decompensated on the wrong side of the functional continuum. You can choose whatever you choose. If you have an Impella available to you, or if you have a CCU with milrinone and a diuretic infusion, you should be able to drop the LVEDP, bring them onto a much safer part of the functional continuum, and then.
So let's say you take him to the CCU, he gets diuresed, he's in a better place from a fluid standpoint. Then what are the next steps here? Would anybody think about? Would you go straight to, assuming that he's not a cabbage candidate, you're going to do PCI, or you're going to do any other testing?
He's 55,
55.
right? So, I mean, he's got an EF of 15 to 20%. I'd have heart failure involved. I'd make sure anesthesia is involved. I'd also get a transplant or VAD workup started for him.
Right.
Because that's real life, right? This is not going to magically change his EF.
What about viability? Would you assess viability?
This is that chronic discussion around Revive's findings around MRI viability. My personal bias is I would get viability, but I'd use PET based on PAR 1, PAR 2 in the Ottawa 5 sub-study of PAR 2, which is, they're smaller studies, but they're randomized trials. And they're a functional test as opposed to an anatomic test, which is what MRI is.
Right.
His right heart is very important. Without knowing the right heart, you cannot proceed further. So right heart catheter, right heart inflammations, valvular inflammation.
Did you say right heart cath?
Yeah.
So
I think it's a big part of it, right?
So at this time, his CVP was about 15, mean PA was about 40 to 45, and cardiac index was about 1.8. So just in the interest of time, I'll keep moving so all of that was done. So we got a PET viability study, and in fact, what we found is that the inferior wall and the RCA system was not viable. So at this point, the whole left system is all viable. So we decided to go ahead. And so we placed an Impella CP. This was after he got diuresed and optimized. And so as is our practice, we used a single access technique. So after we placed the Impella, alongside it, we used a 7 French guide, sheathless guide system. We used the Asahi OCath system, which is a sort of a 7.3 French system that just sits alongside. And then we went ahead to try and fix the left main LAD and the circumflex. So you can see one of the kind of technical aspects of this case was that the circumflex is very, very retroflexed. It almost comes back on itself, which in of itself is kind of, a tricky situation. So we decided to start with the circumflex here. So, and then this is the LAD, proximal LAD again. So we managed to wire it with the help of a Prowler catheter. We were able to direct the wire, take it around the bend, and then started ballooning this. And here's the initial stent. And note there's some, there's what we presume is a pseudo lesion proximally as well. So this initial stent was placed. And after that initial stent was placed, here's our next picture. So now, obviously, there's abrupt vessel closure here at this point. And just to take you a step back for a second, the point of this talk was about impeller, right? Hemodynamic support. But I think the best sort of hemodynamic support is when you don't even realize it's there, right? So in this situation where the right's occluded, there's a proximal LAD, high-grade stenosis, and now the circumflex is shut down, the impeller provided enough support where the patient didn't feel anything. So he's now proceeding with no, he had a little bit of chest pain, but hemodynamically he's stable. So thoughts at this point, what do we think is happening distally here? So
what about the imaging? Just one comment. Imaging. If you have temporary pacemaker in rota, do more rota. If you have impeller in chip cases, you do more angioplasty and stenting because you are more confident, overconfident rather. So this man just needs a simple crossover stenting from left main to, and there is a class 1 indication for imaging.
Okay. So anyway, so just to sort of finish this part of the discussion here. So the assumption here was that this is a distal edge dissection with that stent just placed. So after we recrossed that and just confirmed that with a tip injection here, we were able to then see that dissection there distally to that stent and managed to then stent that distal segment, and we're able to get a nice result there. But now the question I have for you here is what is happening proximally? Now remember that circumflex is very heavily retroflexed. It almost comes back on itself. So what would people do here to, let's assume that you can't get an imaging catheter cross into that proximal segment. How do you decide whether that's a pseudo lesion or if that's something to address?
Pull your wire back to the soft part of the wire.
So that's, I think, what most people would do. You would pull your wire back just to the soft part of the wire to understand. The problem was because it was such a curved and retroflexed vessel, pulling the wire back, the whole wire came all the way back. So then the next picture looks like this. So now you now have confirmed that actually there is a linear dissection right in that proximal segment. It was not just a pseudo lesion. And now you're faced with the prospect of now having to rewire that with that dissection there. So, as you can imagine, this took a little bit of work, but we were able to rewire it, get a stent in there, and rescue that proximal vessel as well. We then turned our attention to the proximal LAD, wired the diagonal and the other branch there. And this is actually the balloon that we used here was a Scoreflex balloon, which is a scoring balloon. There was just a little bit of calcium, but not too bad, enough. And you see there's a nice expansion. I didn't include the imaging runs here, but we had good plaque modification at this point, and then stented all the way back to the left main, and we're able to get a nice final result. So a little sort of adventurous during that with the abrupt vessel closure and the rewiring and a very awkward bend, I would say, at that proximal circumflex, but a nice sort of final result. And then this is the best part of the story. 5 months later, if this will play, the EF improved to almost normal. So 55%, or almost normal, maybe even you would call it normal. So nice result there. So yeah, thank you. So this is my last slide. So just in summary then, so we've just discussed a relatively young guy with the usual risk factors, very low EF initially with multivessel disease who was turned down for bypass surgery. If he was a good surgical candidate, I think he would have been the perfect surgical case. And again, the hemodynamic support here almost became a secondary issue, right? So when you have such advanced coronary disease with such advanced cardiomyopathy, you want to take all of the sort of potential risk out of the equation, and there needs to be some level of hemodynamic support. As you saw there during that case, we had the shutdown of the circumflex. The left main could have dissected. There could have been a number of other things that could have gone wrong. So we were grateful to have the support of the impeller there. And as I said, we did this using a single axis technique where we take a guide alongside the impeller through the same sheath and do the whole intervention through that. I think that, again, as discussed previously, meticulous planning is really important for these cases. And I think that's my time. So thank you very much.
Prashant, great case. You went for a circumflex where dissection happened, etc. You didn't treat LAD with a stent prior to that, isn't it?
Yes, and the reason I did that was because I was expecting to extend this LAD stent back into the left main because the distal left main was involved. So I figured just to make things easier, I would address the circumflex first before having to cross through the stent.
And the second thing is, in Australia, of course, we have impeller, but it's very costly. So cases like this we assess, and of course, if it's shock, you have to use impeller. But as in this case, in CCU, another option is to treat them offload for 5-7 days, and then bring them and vessel by vessel. In my hospital, we do without impeller. Of course, you have extra insurance for yourself, for your patient, but in places where impeller is not readily available, I think it can be done without as well. Yeah.
I think that's true. I think we were grateful that we had the impeller, and given the sort of situation that we ended up finding ourselves in. But I think you could have probably done this with a balloon pump. But I think if you're using lower levels of hemodynamic support, then your point's well taken in that you need to really diurese them, get them optimized as much as possible for a few days before the case, repeat the right heart, make sure the numbers are good before you go ahead. Yeah. But I think that's fair.
Kenny?
Yeah, thank you. A quick point and question. That was such a great case. The quick point is that even from the days of the Syntax study, it's us, interventional cardiologists, who take the worst and the sickest patients, which are surgical rejects, and it's not the other way around, as many people have a misconception that the surgeons do the more difficult cases. But my question is, taking the fact that your PET said the RCA is non-viable at face value and not revascularizing it is something which I probably wouldn't do. I think a dominant circumflex and a dominant RCA to be left and the non-dominant circumflex in a case with in an ischemic cardiomyopathy is something that we have learned from the lessons of surgery does not work. Relying on viability is not the way to go. And they don't have the fine-tuning to tell us that the circumflex area is viable and the RCA is non-viable. I mean, I don't think we should believe that. And, with an impeller, maybe you should have focused more on the RCA than the circumflex is my question.
Yeah.
Yeah, I think that's an interesting point. I think that given the sort of multi-vessel nature and the PET findings, although you're notwithstanding the points that you've made about that, we felt it made more sense to focus on the left system first. I mean, we've still kept the door open to bring him back to stage the right coronary if there was some clinical indication for it. But I think the sort of improvement in his LV function I think justified the sequence. But I think your points are very well taken.
So forgive me, I in my mind, I can't remember the picture of the right coronary. Was it open or closed?
It's occluded. It's there's a proximal occlusion with bridging collaterals.
As you know, so CTOs are near and dear to my heart. But I mean, other than a very straightforward right where you could cross antegrade just to give yourself backup, in Canada, we do have Impella, as Rustam said, it's limited in our center as well, where you have to be careful about when you use it, you have to justify it, use a protocol, whatever. Our approach is to revascularize as much as we can when we're on a pump, because we've actually put the money in for the pump and the infrastructure around it is there, which is why I mentioned the early VAD transplant consult, so that you're aware of what happens, because there's a tiny proportion of these patients where you can't wean. The only thing that I might mention is that in cases like this where you have triple vessel disease, not ones where you've had multiple dissections of the circumflex and you'd had to go back and forth. These are the ones where sometimes I'll think about opening the LAD with a balloon. If I have to use the septals to get retrograde to be able to open the RCA, I'll do that, pop the right open, stick a wire down the right, stent out the LAD, stent out the right on the way out. Having said that, I think it's totally appropriate to just go after the left system, give this guy back everything on the left, and then bring him back in a like in a staged fashion for that right. The challenge I have trying to hang my hat on that approach is that even in stitches, we didn't have that much EF improvement, right? But what we had was an outcome improvement. And we have not been able to demonstrate a material impact on left ventricular ejection fraction beyond 4 or 5%, doesn't matter what you use, except for Stefan Renfrey and Kambas Mashaki's registry, where they demonstrated in the lowest EFs with CTO PCI, you had a jump of just under 9% when your EF was less than 25%. So I struggle knowing whether or not I should just do everything, or if I should stage these rights and then end up staging a right into an LAD where I have to use the septals that are stented across in an EF that's still 15 to 20%.
Yeah. No, I think that's sort of part of the decision making that goes into these types of cases.
That's why I tend to do everything at once.
Yeah, and but I think in this case, the sort of decision was relatively easy in that, there was so much that went on the left side that, it wasn't worth now trying to tackle an RCA CTO in the same sitting. Yeah. So, but as I said, with close follow-up, we can always stage that and bring him back if it's clinically indicated.
Thank you very much, Prashant.
Thank you.
Big hand for Prashant. It was a really difficult case. So we move to the next speaker, Sanjog, and he's very well known, our local hero here, doing great work from Canada.
Good morning, everyone. I did not realize that this was a focus on cases, so I put together a talk of sorts with a case baked in. The case is very, very simple, and so I'm very happy to yield this to discussion. What do we mean by image cut DCB? Well, these are the learning objectives that I thought we would discuss. One, there is an emerging role, but exactly where is it that the evidence seems to point us? Two, what's the role of intravascular imaging in DCB PCI, right? We have a pretty good set of criteria that we follow when we use either IVUS or OCT to define our stent strategies, but how do we do that when we're not suspending a vessel in its largest possible conformation? I'm grateful to have people like Professor Colombo around who can help us understand this. Is there advantage to a scoring or a cutting balloon pre-DCB use, or will POBA do? And can we define a simplistic approach to optimize our DCB use? So there's lots of evidence, right? There are many, many observational studies, some retrospective studies. There's only a handful of RCTs, sort of in small vessel coronary disease is probably where the most evidence has been generated, around 11 to 1,200 patients. And then a good deal with ISR, with ISR Desire 3, RIBS 4, and then of course the Agent IDE study that came out recently, all of which are starting to suggest that maybe in places where stents are known to fail early, so small vessels, very distal disease, repeated stent layers, a DCB is an appropriate alternative. But the question is it the right thing to do in everybody, right? We have some observational evidence in high bleeding risk patients, elderly people where you're trying to conserve DAPT, and then there are some people that are using it in ACS. So this is probably the most stark evidence that we have in the last few years from the Agent IDE trial that would suggest that at 1 year, TLR is a good deal lower with DCB versus just plain POBA in stent restenosis. In small vessels, we have a patient-level meta-analysis that was published earlier this year by Bernardo using data from a number of trials and patient-level data that showed MACE rates seem to come down to actually 2/3 of what you see with stents when you use DCBs in small vessels. The challenge is, what does small vessel mean, right? Is it 2.5 millimeters visually? Is it 3 millimeters visually? Is 2.5 millimeters visually actually 3 millimeters? Because we now have had it drilled into our head that the vessel that we see is not the vessel that we're treating, because we know when we use the intravascular imaging, it's a totally different substrate. And interestingly though, even though MACE rates seem to be lower, target lesion failure doesn't seem to be any different at 3 years. So it's sort of somewhat perplexing, but rational that we see lower troubles in distal vessels and small vessels with DCB use, given that we know small stents go down early. And then that flies in the face of use right across the board, and particularly in large vessels where we have a doubling of the event rate in large vessels with DCBs in REC cage-free 1. So how do we start to close this gap, right? What is it that fills the gap so that we can start to have a level playing field and use DCBs more uniformly? Well, this is a great slide from Gary Mintz that I refer back to every time I can. And this proves that, just because we've become more facile with intravascular imaging and that we're better at actually reading the images and predicting size, that doesn't mean that we're any better at using angiography-only PCI, where when you compare people who've had angiography PCI in yesteryear versus those who've had them more recently in more recent studies, we actually find that the post-PCI diameter stenosis and the ultimate outcomes are still just as bad using purely angiographic-guided PCI now as they were previously, suggesting that just because you've done intravascular imaging and you say that you have IVUS eyes, you don't, right? And the imaging actually does contribute a great deal beyond just what the size of the vessel is. We just had a great session earlier about how there are all kinds of subtle imaging findings that you can't see on the angiogram alone. So consider this relatively simple case. This case is the mother-in-law of our head of cardiac surgery. So lovely, lovely lady. She came in, had a STEMI, fixed her circ, and then in this second procedure, I fixed the proximal LAD and a very distal LAD lesion. Then we had this RCA, which had some bridging collaterals across what was probably a recanalized CTO with a number of different pathways going through it. And so I crossed this, I ballooned it, we stented it. There was no magic here. This was a simple, straightforward antegrade crossing. And then to my horror, this is what I saw after I put the stent in. And this is the problem with distal vessels and CTOs, isn't it? You don't know what the distal vessel flow is like unless you do a dual injection. In this case, the majority of my collaterals were antegrade from that bridging collateral, and I was pretty sure I was just going to get a cross. Having said that, I tapped myself on the hand after I was done this case and said I really should have put in a secondary access in case I didn't get it through the first time, because I probably would have seen this. And now that I've worked very hard to IVUS guide and stent this thing, I've got a horrible long distal vessel that's got a ton of disease in it. And I don't particularly want to add another 48 to 52 millimeters of stent in this 84-year-old woman that already has a bunch of bleeding risk factors. She needed hip surgery for what it's worth. So how do you approach this distal vessel? Do you just carpet bomb it with another big long stent? Or do you take a different approach? So the DCB simplified approach is 1, use IVUS to define your preparatory strategy. 2, after you've prepared, re-IVUS to ensure you actually achieved what you went there to achieve. So a relief of the stenosis, no large enduring dissections, no massive hematoma in the wall, and good preparatory lumen, right? A good lumen that you've achieved. And then finally, treat your lesion with a DCB. So there's a lot of different morphologies that we can see. This is an in-stent group of morphologies. We saw a lot of them in the imaging presentation earlier where we talked a little bit about smooth neointimal hyperplasia versus calcific neoatherosclerosis versus what stent undersizing looks like versus under expansion versus an appropriately expanded stent just with a very positively remodeled vessel. And we have to know how to read each of these images to be able to make good decisions. That's a little different than the classical ones in de novo lesions though, right? Where we have mixed plaque on the left side here. And this is a picture of that lady's distal right that you just saw. And then you have bits of fibrotic plaque and then calcific plaque in the distal part of the vessel where it's not particularly thick calcium, you can see vessel around it, but it's calcific plaque all the way around. So how do you prepare these? What is the approach that is to be used? So some people will say just balloon it and see how it turns out. And I don't think that's an unreasonable approach. But I propose a different approach based on some very early data that need to be randomized and studied, right? Where we know that when you take conventional 1-to-1 POBA, because there's stress longitudinally along the entire intima, you do actually get a fair amount of injury into the vessel wall. And what can happen then at 14 days is you start to develop thrombus, and following tissue injury, you start to develop an inflammatory reaction. And so the question is this the right way to prepare every vessel, or maybe is there a different way? And what we talk about now as the benefit of cutting balloons is maximized impulse on specific spaces, right? So what you're doing is force modifying at the end of tiny atherotomes to be able to split plaque, and most importantly, reduce the tensile strength of plaque, because it is the tensile strength of fibrotic plaque and calcific plaque that ultimately results in late lumen loss and recoil. That's what you're trying to get a hold of. But what you're trying to do is concentrate your force on atherotomes so that you're not injuring the rest of the vessel wall with what effectively becomes the POBA section of the balloon, right? And this is just to show you that atherotomes are actually pretty small, right? This is a roughly half the size of the thickness of your standard 014 wire. And for what it's worth, there is a little bit of stuff out there, and there's a variety of these, ISAR-3, et cetera, where they've suggested that cutting balloon angioplasty maybe is better than plain balloon angioplasty, but it has yet to be really subjected to a rigorous, appropriately powered randomized trial in the setting of DCB use. But we can take some lessons from peripheral angioplasty, right? So this is some studies that were done by a group in the UK that looked at peripheral angioplasty specimens where they had circumferential calcium throughout these vessels. And what they did was use standard balloons versus cutting balloons. And what they saw was that reduced vessel compliance resulted in late lumen loss. And interestingly, even at 24 hours at the best of times where you're only getting 5 to 10% of drug on the balloon into the vessel walls, who knows what it's going to be like when there's a ton of atheroma that's thick and that won't split. And so this makes the argument that maybe this is an appropriate thing to do. Taking additional vessels from peripheral angioplasty, we realize that when you look at calcium in the SFA and the POP, and you actually treat them with atherectomy, and then you apply paclitaxel, and you stain them with an immunomodulator or an immunostain substance, what you see is that in the individuals who actually have breakage of the calcium and atherectomy, you get way more penetration of paclitaxel than you do in the individuals without that penetration. Now, this is peripheral angioplasty. I'm not saying that it's the same as coronary. I'm saying that perhaps this is a place where we know there is room to grow. We have some very early stuff that are kind of in vitro models where we've looked at rabbit iliac specimens where they've applied POBA versus cutting balloon and then a drug-coated balloon. And what they see is that the amount of medial smooth muscle cell loss, and most importantly, the angle, so the width of the drug application increases when you seem to use a cutting balloon. And so for me, this is what drives, I think, the rationale of a study like this, the Nature trial, which is being done in Japan right now, that is actually looking at what the right way to prepare this is. Do you wait for an FFR that's normal? Do you wait for a lumen that's better? Do you wait for splits that you can see in plaque, or something, or some combination thereof? So moving quickly across, this was the IVUS in this person's distal vessel. You can see some dissections there. That was from the wire going through that we didn't know were there because there was so much plaque we couldn't see. There's mixed plaque, there's a little bit of calcification. And so we did some cutting balloon angioplasty here, low pressures, sized to the lumen, slightly above nominal, so that I was getting into the wall, but I was not splitting right out to the adventitia. And this was the IVUS recheck. So this now shows you that you actually have gained reasonable lumen, that you actually have stabilized and split a bunch of the dissections, released the hematoma that was in the wall, and that you have no more stenosis. So that we were able to achieve this DCB deployment and this final result, which I was shocked by because I didn't think it would look that good when I was done. And she now is about 6.5 months out. It's not that old a case, but she's doing very, very well. And I've got her onto a single antiplatelet agent, which I was very pleased with. So what I took from this is that we're sort of running back into a stage of advanced balloon angioplasty now. We're not stenting everything. And I think there's a learning curve here. There's a bunch to learn now about how we do this right. So careful understanding of vessel sizing, not going after the total split of everything because you know you're going to put a stent in, might be the appropriate approach, but instead splitting plaque and maintaining vessel architecture is what you're trying to shoot for. And I think intravascular imaging really helps you define the right preparatory strategy, the right sizing strategy, and then ultimately vessel selection for when you should stent up front or when you may want to use a DCB. Thanks very much.
Yeah, thank you, Dr. Sanjog. We are fortunate to have Dr. Colombo in the hall, who is a master of DCB. Can we have your opinion, sir, whether it is limited to small vessel, side branch, ISR, or for all vessels? What is the importance of imaging? It should be mandatory for all DCBs or not?
You know, if you can afford intravascular imaging, is good for everything. So I think it's a matter of skills and economic support and time. But I totally agree that cutting balloon is a very good approach. We underutilize this device. Preparation. So I totally agree with what you said. And the difficulty is do the planning, know if you have to use DCB before. The decision 80% of the time comes after lesion preparation.
correct.
You think you can, then you get a lousy result, and you place it. We should.
I think to that point, which is very well taken, that is why the sort of simple 1, 2, 3 is you IVUS first to understand what you're treating. You treat it, and then if angiographically it looks okay, you IVUS it again to make sure you've actually achieved the result that you want, because the angiogram is less sensitive. And then once you've got the result that you're reasonably satisfied with, I think then a DCB is quite appropriate. But for what it's worth, that right coronary artery was clearly not a 2.5 millimeter vessel. It just looked like a 2.5 millimeter vessel because it was the end of a CTO, which is yet another challenge with that group of patients.
Sanjog, I have two questions. One is, would you treat prevent-like lesions with the DCB? And second, you know now that bioadapter stents are superior than conventional DES. And we have cage-free and sweetheart studies called registry of 8,000 DCB. They're as good as DES, up to 3 millimeter of vessels. Mm-hmm. So if you do the network meta-analysis now, do you think the bioadapter stent will beat DCB, and that will be the standard of care rather than DCB in the proximal de novo lesions?
I have no idea. I think that's why we have trials. I think that actually, it's a good question. But I think there is a lot of jeopardy in taking totally different data sets and the conclusions of those data sets and trying to compare them when they're asking different questions. The fundamental preparatory strategy associated with stenting is different than the fundamental preparatory strategy associated with DCB. It's different in size, it's different in aggressiveness, it's different in type of plaque selection. And so I think the question is a worthy question to answer, but I don't think that we have enough data, and I admit I'm a bit more, a bit more conservative with this piece. I don't think we have enough data to be able to wholesale sell a 4.0 DCB in the proximal LAD in a 43-year-old male patient with a simple lesion yet. I just don't think we're there. Maybe we will be one day, but if it's my LAD, please take a 4.5 millimeter stent and put it in there and post-dilate it, and I'll be happy.
Yeah. Prevent-like patients.
Prevent-like patients, with non-obstructive lesions. Again, I think Prevent looked at this and suggested that you'd have to do basically 800 PCIs to prevent one event, right? So I don't think Prevent makes a lot of sense from a preventative PCI perspective. It certainly doesn't make sense putting stents into proximal vessels. Whether the DCB is the same thing, I don't know, because ultimately with Prevent, what you're doing is treating a lesion that is high risk of rupture. I don't know if applying a bunch of drug to the top of a thin cap is going to change that. Having said that, the preparatory strategy, I think, is really what may result in a controlled rupture of that plaque so that it arguably has an inflammatory response afterwards and you get a thicker cap that comes after. All reasonable questions, zero data to answer them today.
Yeah. DCB is a very, very fast growing area. It's been there for 15 years, as we know, since Germany, Italy. But as you start to use it more and more, your indications will expand. Yeah. Of course, it's ISR, it's small vessel bifurcations. Then you start doing blended therapy, proximal LAD stent, a couple DCBs. Then you'll start doing de novo lesions. But the key is lesion preparation. Yep. And imaging is very important. Again, once you have experience, you may sometimes skip imaging as well. And often you need IVUS only in the first run to understand the size of the vessel and to understand the composition. You don't need to repeat IVUS after preparation, because angiographic assessment, your balloon expansion 1-to-1 will tell you if a lesion is ready for that. And another thing is there are so many ways to do it. As you mentioned, you went 1-to-1 with cutting balloon at low pressure. Other option is to do, let's say, 4.0 vessel, take 2.5 or 3.0 cutting balloon and go 18-20, but then take 4.0 and C and run that. So there are so many ways to do it. The key is to have angiography that shows you very good preparation, no type C or D or so staining, no dye hanging, and no recoil. Then you're good for DCB.
No doubt.
Thank you very much, Sanjog. And a big hand for Sanjog. It was a very good presentation. Over to you, Rustam, for a new technique coined by you.
Thank you for invitation. later this evening, I will present a case that I presented 5 years ago, but with follow-up, and that case traumatized me, and this technique is stemming from that. So that case was about ostial circumflex perforation. So when we talk about serious calcium, it's a combination of those things. It's a thick, eccentric, 360 degrees, ostial, aorto-ostial lesions, or dog boning stent in the calcium for many years. And sometimes we have to do combination therapies, rotacut, rotashock, TRIPSI, sometimes laser combined with cutting, etc. So Robital is similar. It's intention to treat the lesion with orbital atherectomy. For example, retroflex nodular ostial calcium in the circumflex. And you want to glide assist and treat back, glide assist, treat back, and so on. If you take rotational atherectomy there, you may perforate. That happened to me. So often to get orbital through your lesion, it's difficult because it's so calcified and tight. That's why you need 1.25 or 1.5 rota to deliver that. It's very small niche of lesions that you will need, but I just thought I'll show it to you so you can consider this. In Australia, cost of orbital is twice cheaper than shockwave. Shockwave is very expensive. So combining rota with orbital, it will be price of one shockwave, combined therapy. So this is the first case of Robital that I did. Does it show? Yep. Okay, so this was a father of an interventional cardiologist. In Australia, you cannot treat your relatives. So he was referred to me, and it was in...
Hello, audiovisual, can you fix up this monitor? We can't see anything on this.
It comes on the big screen, yep. Anyway, so...
This one.
EF 45%, bad kidneys. 4 years ago, he had lima to LADN diagonal and left radial to right PDA. Circumflex was not treated because ostial circ was only moderate.
वो लगाना HDMI
पहुंच गया मैं मीटिंग में घर पे गया
I think you should be good to keep going. I think we've got...
Okay, good. So this is an angiogram. I cannot move the slides.
Hello, audiovisual team, can you just assist him to?
Maybe restart. Yeah.
This one?
No, up, all the way up.
ये नहीं है, 1 मिनट हटाना.
Let's move up all the way. Yep. No, up all the way.
Huh?
I'll show you. Okay, so let me. This is an angiogram of the graft to PDA from 4 years ago. It's fine. Then left main has a significant disease. Lima to LAD diagonal is working. So circumflex is the problem. So at this stage, I thought how to, it's a protected PCI, obviously, left main, but the idea is to treat left main to retroflex circumflex. So I decided to use rotablation first. I was 7 French. I thought I will take 1.5. And with Robital, I have done cases with 5 French as well, but typically 6 French is enough. So here we need to treat circumflex. And this is 7 French. System via radial. So I delivered fine cross to LAD, swapped to extra support wire, and did 1.5 rotor. But that would not create enough space. Of course, I can take 175 or 20 burr through 7th French. But my intention is to treat circumflex, retroflex circumflex. And I want to do it with orbital. So I decided to now, after, I'll just skip that, this after polishing runs, I changed to Viper wire and then I delivered orbital. Because I thought if I now balloon left main-to-LAD, I may lose the circumflex. So again, A-team, antegrade, and you all did orbital, you know, so and then 3-4 times. Then I went same safety check. It was my first case, so I did a bit of extra contrast. And then orbital at 120, both ways. And then I thought, you see, there is more space now left main-to-LAD, and I thought I will do just with Fielder, but it didn't work. And I thought I will do reverse wiring, but I brought with me just in case a Supercross 120. They didn't have it in that hospital. This is delivering 120 on a workhorse wire, and then pulling back the wire and rotating the Supercross, and just BMW universal, and just advancing it back. So now we have control of the vessel, and then through trapping we changed through fine cross to rotor wire, extra support that we already had. It's both machines are on the table, so it's relatively quick. Then rotor, took a bit of time, then polishing, then changing to wire fine cross to orbital. That was the main idea of the therapy. Again, glide assist forward, just to go across the lesion, and then treat backwards at 80,000. And repeat it a few times like that. And then did the same retrograde with 80 and then 120, eventually both ways. And often for circumflex lesions, I like to use cutting balloon as well. So you can call it even RobiCut or something. But it's not often I add third device. So did imaging that time to understand vessel size. It was 4.0, at least at the ostium of the circumflex. So I took Wolverine, 0.5 less to high pressure, 1820, did the whole run a few times, prolonged inflations by 30 seconds. Because I'm looking for long-term circumflex ostium is often coming back a few years later. I don't want that. So placed first Megatron, and then 4x24. Then optimized the top with 5 and left main preparation. I don't know why it's doing that, but anyway, prepare it. Then again, imaging control. Then a second 4x16 Megatron made at 5. Image control. This final result. So once again, Lima to LAD diagonal is working fine. So this is before and after. And second case, 82 years old man with non-STEMI, EF 30%. I should probably brought my laptop because I don't know why it's not working. But you can appreciate quite bad distal left main disease, bifurcation, LAD also, and his small non-dominant right. 2 days later, he was surgical turned down. I put a balloon pump, 7 French radial. It's very difficult. On laptop, it's working really well. I probably for evening, I'll bring my laptop. But anyway, I'll explain to you. So this time I did rota, LAD, and circumflex. Then immediately I did orbital in both speeds in the LAD and circumflex instead of opening 2-0 bird, because its EF is 30%. Orbital is a safer device, I believe, with smaller microparticles in severe aortic stenosis, in depressed LV function. So that's why I did combination of those two. Orbital, I thought, would not go in both of the vessels. That's why I needed to create rota runs first. Okay. Then I did NC balloons in LAD, then Wolverine both axis left main to LAD, left main to circumflex at 3-0 high pressure. Then deployed Megatron left main to LAD. Often nowadays I do DKT, Stefan Rindfranz approach. It's also very simplified, but this time I decided to do TAP. So I did 4-0 pot, and then rewired circumflex, opened the struts, and brought a second Megatron 3.5/8. And then did kissing, and final result. So it's a sick patient. Obviously, if I put Impella, I could do more things. I could do just simply 2-0 rota by 7 French in both limbs. But I thought this is a safer way to do it, treatment with orbital, but do rota to deliver orbital, because it was very calcified. The same technique can be used in the large 4-0 diffuse calcified right eccentric right coronaries, for example. Can be done in left main. And again, it's very comfortable on 6 French. Obviously, here, both cases, I use 7 French because of the nature of the bifurcation left main. It just gives you more options. And I have done case with 5 French as well, where we spent 2 hours, nothing could go. We wired the left main LD via diagnostic catheter, then did extension, brought 5 French guide, and did 125 rota, and then orbital. So with 125 orbital, we could treat left main nicely. So it's before and after. I apologize for this quality, but it always worked. Maybe the volume of runs and the server is not is struggling. And also can be used in all dog boning ISR. A recent publication from Henry Ford from Kalala SWAT showed that orbital is also safe in series of 50 cases of dog boning calcified ISR. Any questions?
Yeah, sorry for those video glitch.
No, I think
compatibility issues.
Yeah.
So we'll take comments from the experts.
Yeah, great results in the end, and for all of those cases. I guess just to play devil's advocate, I might sort of push back for a second and push you a little bit on the rotablator orbital sort of theory there. So was there any imaging after you did the rota that sort of convinced you that you also needed to use orbital in addition?
Not really, because in these cases I cannot do imaging because it's only kind of wire crossable lesions. That's when I use it. But in certain lesions, for example, retroflex, calcified ostial circumflex, where the nodule is opposite carina, and if you do rota, the bigger rota, it will just skip it, and you will damage carina that I'll show you tonight. And in these cases, you need orbital retrograde treatment. But you cannot deliver it because of the tight lesion. So you need to create a channel with rota 125-1.5. It's very small niche of cases, but this can be considered because yes, you can do, okay, you create a channel with rota, but then you cannot still treat this calcium. And then 2-3 years later, this circumflex comes back with ISR of your stent because your original treatment is not done properly. Even though we use cutting balloon, we think we're good, but they still come back. So, I mean, there is no trial with a follow-up, but so far the case I have done, they're doing well.
The only other point I'll make, we've been using coronary orbital atherectomy since it first came out. So we've been using it for at least 12, 15 years. And the one caution I would have for you specifically, I think it's true with any atherectomy device, but specifically with orbital, in the angulated retroflex circumflex, be very, very careful. Now, your technique was excellent and you had no complications, but if you look at all the case series of orbital atherectomy use, the highest incidence of perforations happens at the proximal circumflex, especially if it's retroflex. So the risk of perforation in that zone is extremely high. So if you do make the decision that you're using this device in that area, you have to be very meticulous with technique, very slow, on the pullback, low speed, etc.
I've seen bad cases happening when a lesion is almost uncrossable and people try to go with orbital and do bad things. Here, you create a channel with rota and start orbital treatment 3-4 times only on the way back. Glide assist and on the way back.
Thank you, Rustam, and a big hand for your
But remember, this can be done with 5 French. Okay. Yes, we know 125 rota goes through Medtronic, but it's not enough. What else are you going to bring? You cannot bring anything bigger than it, but you can bring orbital.
Thank you. Thank you very much. Kirti, over to you, your presentation.
I have to say thanks, Atul, for having me here. I want to start by saying that my case is going to be simple because I think to deliver a message, it's very important to keep it simple. I also think I want to make a marketing pitch. To have a seamless presentation, move to keynotes. That's it. But so left main PCI, we know that we all have got onto it. The problem is there's a large portion of patients who come back because this is an extremely unforgiving anatomy. So here is a story of an 82-year-old who presented to me with unstable angina in 2017. And you can see that he's got a heavily calcified left main distally that progresses into a ostial circumflex lesion. And further on in the proximal circumflex, there is more stenosis there at that OM branch. And because it was calcified, we had an IVUS catheter which failed to cross. And so our device of choice is a rotational atherectomy. We use a 1.5, which is our default burr in most of these cases. This was in 2017, and for calcified lesions in the left main, my protocol was to use a single burr, 1.5, and then go to a standard size Wolverine catheter to do a rota cut, and then try to get stents in with whatever technology that we would have. Based on that, we did an IVUS, and you can see the upper row is the left is the left main, which is a 4.75 mean luminal diameter at a landing zone. which goes into an LAD, which was a fairly crescentric lesion at the ostium, as you can see in the upper column there. Is that a pointer? There. So you can see the LAD lesion is very crescentric with the circumflex staring right there. And you can see the area is, though acceptable, I think one needs to look into the fact that once you start treating the circumflex ostium, you're going to compromise it further. And of course, the landing zone is fair, almost a 3.75 to 4 artery. The circumflex, on the other hand, is an extremely crowded, fragmented calcium kind of stuff at the ostium, more calcium, then a ring of calcium at the level of just beyond the OM branch, and a landing zone of around 3.25. And this was almost 20 millimeters downstream from the circumflex artery, from the ostium, and this is a short lesion, just 12 millimeters outside the ostium of the left main. So having said that, what we did was we used for post-rota, we did a cutting balloon preparation with 3O in both those arms. And then we used simple techniques of DK crush, stent 1, stent 2, as defined above. And this is the result we got angiographically. So we had moved into the point that we wanted to define results of left main based on IVUS. And when we look at the IVUS images of the corresponding areas, we realize that there was the left main proximal, the left main distal, the confluence, the circumflex, and the LAD. And if you can look at the values are fairly simple, and except for the fact that 6.6 stands out over here in this crowd, especially because the distal circumflex was 9. Remember, this was 2017. And we all believe that if we got something more than 6 over here, we would be okay. And that's the change. That's the thing that I want you to keep that table in mind. He had recurrence of symptoms in 2021. And he came back with that circumflex looking tight over there. It was critical. He also had more progression of disease because of a progression of this right coronary artery, which was FFR negative in 2017. How do you manage this ISR? And I think what we did, our procedure was we had to do something different. The first thing is you need to analyze what you did in the past to see if you can make changes in your current strategy, which is going to make a difference. And so what we did this time was we chose a 1.75 rotablator burr. We used an IVL shockwave. This is following a 3.5 cutting balloon. We used an IVL shockwave and expended those 80 pulses at that spot. Used a single stent from the circumflex to the left main. Of course, we opened up the struts into the LAD, and we gave a pot of 4O. This is the final result that we had. And what we had done, essentially, is that in 2017, we had got around 6.6 as our ostial MSA. We improved that to approximately 10 point, around 11 point something with this strategy. So what was important is that we were able to change the circumflex result, which was now present in the ISR. It looked like this. We had been able to expand it well. And what did we do different? I think to achieve that result, we did, in 2017, we used a rotablator 1.5. Here we went and did a more aggressive rotational atherectomy. We used a 3.5, but we went in and did more to do something to the calcium. And then, of course, we did not use a DK crush. This is a typo here. We used a single stent this time, but both I was guided. And I think we had the opportunity. In 2024, this gentleman had a syncopal attack, and this was the reason. So we got him in to get a dual chamber pacer in. And at that time, coronary angiography shows white patency. There's a 40%, 50% ISR at the circumflex, but he's without any anginal symptoms. So what do I take home from this? TLR, as a result of underexpansion and undersizing from an inadequate lesion preparation is the most common cause in the circumflex ostium. Plaque prolapse or a deformed stent is the other thing which one needs to take care of. Image guides us to the cause, and courses a correction too. And I think we need to be able to go back and reflect on the index procedure to be able to do something different in the current one. And a redo of the left main requires almost always a different approach, a different strategy, and we need to be able to improve upon the previous MSAs substantially. And I think I'll close over here to be able to discuss this. Thanks.
Yeah, excellent case, Dr. Kirti, as usual. And circumflex ostium, whatever you do, we know is a notorious subset for outcome. Do you think is it really under expansion, which in a given case could be under expansion, but not able to, 6 is not a very small area to, circumflex ostium to decide. Even if newer criteria is 7, it's not 5, it is 7. So achieving 12 is not practical always in a calcified circumflex like you achieved. So what is your point in this?
So I think if I were to be allowed to go back to the first IVUS image, which is here, I think this IVUS, if I can have that slide, I can actually explain this story. Can I have the slides for a moment?
Can you switch back the slides, please? The last slides.
Kirti, by the time you switch off slides, can I just one small thing? Yeah, Kirti here.
Yeah, sorry.
Yeah, please.
Yes,
do you think that in practice, LCX osteal is much more fibrotic and non-resilient and elasticity is much more as compared to LAD osteal?
I think that both the ostia are notorious. Leaving a slightly underexpanded stent in the mid-LAD or in the mid-segment of an artery is forgiving. But at the ostium of the circumflex and the ostium of the LAD, when you undersize or when you underperform in those areas, it's not forgiving because they tend to come back. And the reasons could be plenty. The reasons could be the dynamic nature of the ostium of the circumflex, and therefore, I think the futuristic strategies for left main would be to be able to have just a provisional stent with a DCB after a great preparation of the circumflex, really. But if I can have that slide back, hello. Can I have that slide back, please?
Yes, it's on the screen.
It's already showing, yeah.
Oh, it's already showing.
The other side.
It's okay. So here is the issue. I had a landing zone in the LAD, which was pretty good. I know that my distal LAD is still underperformed. If it was 18, I should have gotten close to 15, at least in the distal LAD. But look at the proximal LAD is 6.6. When distally downstream in the circumflex, the ostium circumflex is 6.6, but distal downstream is 9. It tells me that this was a 3.5 artery 20 millimeters downstream. That means that the ostium, I should have at that time expected that this was a 4-0 artery, and I did not. And it is important that when you do imaging and when you look at an MLA, which is downstream, and you're not able to understand what is happening to the EL at the ostium of the circumflex, which is difficult to visualize, I think you have to assume that it is going to grow as we come proximally, almost 0.3 millimeters for every 10 millimeters that we come back. So my destination endpoint for the circumflex should have been 12, at least 10.5 here. And I underachieved, which is why, and we all do that because we kind of practice defensive angioplasty, especially when it comes to left main, and we want to quit when it's hit on the angiogram, but you need to quit when it's hit on the IVUS. That's what I think.
One last comment from Antonio.
I agree that if you get a large lumen is always better. That's everywhere. But I think even with a large lumen, if you wait long enough, you will gonna get restenosis. Because the ostium of the circumflex is more complex. There is a shear stress, the stent keeps the movement constrained, so there are more complex factors. I'm not so sure that DCB is a solution, but I know that stents is not very good. But I don't have the solution.
Thank you very much, Kirti. But before we end this session, we have a person for whom it's a very special day today. And Sanjog Kalra, it's his wedding anniversary. So I would request everybody to give him a big hand and wish him his wedding anniversary. Thank you for being with us, Sanjog. And thank you to all the chairpersons, moderators, and experts on this session. We bring an end to this session. And with this, we move forward to a small, short, brief, quick inaugural. And I'll invite the CEO of Fortis Healthcare, Dr. Ashutosh Raghuvanshi, to come and speak to us, and some more friends to come onto the stage. Mr. Anil Vinayak, Dr. Gary Rubin, Kirti, Dr. Eberhard Gruppe, Dr. Antonio Colombo, Horst Sievert, Kirti Punamia, Gulio, Dr. Pradeep Yadav, Dr. Giza Fontos, Sanjog, Prashant, you're there.
What happened to Gary on the flight from Salt Lake City?